Hey guys, this is Dr. Charity Stanley, and today we're talking about what happens when good adrenal glands go bad. So we may have to take them out, and that is called an adrenalectomy. So this is surgical removal of the adrenal glands. Once we actually remove the adrenal gland, we likely will need to replace the hormone that is being produced that in the area that we removed. So, nursing actions, a patient who has had their adrenal glands removed are super sick. Patient will come back to the ICU. They'll need to be on steroids and other hormone replacements. You're going to need to be monitoring for an Addisonian crisis due to the drastic change in the cortisol level being produced. So, findings for this include hypotension, tachycardia, tachypnea, nausea, and headache. The vital signs need to be monitored, and you need to make sure your patient is hemodynamically stable by monitoring the vitals every 15 minutes. You'll be also monitoring fluid and electrolytes. So, checking the belly for distension, bowel distension, tenderness, checking the incision for any redness, swelling, discharge, and your patient will be NPO for a little while afterwards. And this is going to be a procedure in which you slowly reintroduce food. This isn't something that they can come back and eat a regular meal immediately. So, complications that can happen, you can get a perforated viscera. This is where it was accidentally cut. Bone fractures due to hypocalcemia, have infections due to immunosuppression as a result of the removal of the adrenal glands. And you can throw yourself into an Addisonian crisis. That's where you're not producing any cortisol at all. And you need to have cortisol on board to be able to function in a normal manner. So, first of which is a perforated viscera. This we need to check for evidence of GI bleeding. We're going to be checking for black tarry stools or used coffee ground like throw up. That both of these will stink very badly. Administer antacids to help decrease the pH. To increase the pH to a normal level, and avoid aspirin or any kind of NSAIDs because this can increase bleeding. So this is a video that's on the PowerPoint that you guys can watch that will further explain this. And this is what ulcerations look like within the GI tract. So unfortunately, it's a pretty common phenomenon, and you can't tell when they're bleeding because the ulcerations are so well hidden within the GI tract. So bone fractures, if your calcium is too low, then your bone fractures will be more likely. So you need to use caution when moving the patient. Make sure that they're listed as a fall risk. Make sure their rooms remain relatively clean to be able to provide clear access to the door and also to the bathroom. And their diet, they need to be on calcium supplements and also vitamin D supplements. Remember when we talked about the parathyroid, that parathyroid hormone has to bind with vitamin D to allow the stomach to open the calcium doors and be able to absorb calcium. And the other thing is, don't tempt fate. So you don't want to do any kind of dangerous activities where falls are likely. So these are several different types of bone fractures. The first is a transverse. That's just where the bone fractures in the center of the bone, and it's usually a complete fracture if it's a transverse. A linear is a crack in the vertical part of the bone. Oblique, the oblique bone fractures, if they're non-displaced, what that means is that the bone is still in alignment. An oblique fracture can also displace the bone. Spiral fractures tend to happen in like a twisting motion. So, for instance, if you're jerking a child up off the ground and you're twisting the arm as you pull them up, then that is likely a spiral fracture. Green stick fractures are also common in kids. And a commuted fracture is the last type that we'll be looking at. Infection is common due to elevated glucocorticoid levels and within adrenal diseases. And so you need to monitor for signs of infection. Be notifying the physician with temperature increase, if you're seeing localized swelling or streaking type redness. Monitor the white blood cell counts and look at sources of potential infection, urine and skin. And you want to minimize exposure to infectious organisms, so avoid crowds. So adrenal crisis, this is an acute adrenal insufficiency. This is a sudden drop in corticosteroids. Often this is due to having surgery and removing an adrenal tumor. It can also be due to stress or to illness, to surgery, dehydration, or you just frankly just take away the steroids quickly and the body is still dependent on the supplements. When you withdraw that medication, it can throw you into an Addisonian uh, insufficiency, adrenal crisis. So, indications, what your patient's going to look like. They're going to have low glucose, low potassium, abdominal pain, may have weakness and hypotension. So these are all symptoms of an adrenal crisis. Joint pain is common, hypotension, hypoglycemia, hair loss, back pain, confusion from the abnormal electrolytes, and vomiting. So what you need to do as a nurse when your patient has an acute adrenal insufficiency or adrenal crisis? You need to monitor vital signs and their glucose levels to figure out how stable they are. Do an electrocardiogram to be able to see if there's anything weird going on with the heart. During time periods of stress, you may need additional glucocorticoids to prevent an adrenal crisis. So you'll be giving these glucocorticoids as ordered. You may also be giving insulin with dextrose. So that's kind of an oxymoron. You're putting sugar in, but you're also putting insulin in. But what happens is that will actually alter your potassium and it will help you to excrete potassium and pull it out of the blood. You also can do things like sodium polystyrate, and that is going to bind excess potassium to help decrease the potassium in the blood. And another way, just frankly, give them a loop diuretic and don't replace that potassium. And so that will also help the potassium to move from the blood and move it into the cells where it can actually be used. And you may need to treat dehydration with IV fluid replacement. Okay, so going back to Cushing's syndrome, this is you end up with the moon faces, the hunchback, the truncal obesity, the striae, the stretch marks, may end up with weak bones. The skin is very, very fragile. And in males, you may have gynecomastia. So Addison's disease, Addisonian crisis. Addison's disease is due to adrenocortical insufficiency. It's caused by damage to the adrenal cortex. So what's happening is you're not producing the mineralocorticoids, which is the aldosterone, and you're not producing glucocorticoids. So this results in less cortisol and less aldosterone. So an Addisonian crisis happens quickly. It is a true medical emergency. And if it's not quickly diagnosed, your patient is in big trouble. Risk factors for primary Addison's disease. This is going to be immune system, autoimmune system dysfunction. Could be exposure to histoplasmosis, tuberculosis, having had adrenal gland surgery, different cancers that have metsed, and radiation therapy of the abdomen. So that can actually damage the adrenal glands. Other risk factors to develop secondary Addison's disease is going to be steroid withdrawal, a hypophysectomy. Remember, that's where we cut out the pituitary gland, pituitary neoplasm, a tumor on the pituitary gland, or large amounts of radiation exposure. So risk factors treated, it is a major cause of death. So other things that are involved with it is sepsis, a blood infection that's causing multiple organ shutdown, trauma. It can be a car wreck. It could be any kind of surgery, stress to the body, exposure to cold temperatures, having less fluids in your blood than your body would prefer, hypoglycemia, or even steroid withdrawal can cause Addisonian crisis. So you're going to be looking for the signs of Addison's disease and manifestations of acute adrenal insufficiency. They tend to develop rapidly, whereas chronic conditions is like Addison's disease. But an Addisonian crisis is this acute adrenal insufficiency. So expected findings, you're going to be craving salt because what's happened is you have hyponatremia, you have the diminished pigmentation. I'm sorry, not diminished. You have extra pigmentation. So remember John F. Kennedy and how tan he was, like a bronzed look. Weakness and being tired is very common. You're not holding on to salt, so you're not holding on to the water, so you're going to see a significant weight loss. You may also have GI problems like constipation or diarrhea. So this hyperpigmentation is due to increase in the melanocyte stimulating hormones. So this affects skin color and appetite in both humans and other animals. So there's several groups of hormones that are produced by the pituitary gland that contribute to hyperpigmentation and the excessive melanocyte stimulating hormone. This is what really is the key factor in promoting darkening of the skin. So this is what Addison's disease looks like. You're going to be looking for bronze, darkened pigment of the skin, disruptions in body hair growth, GI disturbances. Remember, they can present with constipation or diarrhea, weakness, low blood sugar. They may have postural hypotension. So you need to change positions very slowly with these folks. And they may be craving salt because of the lack of aldosterone. So examples of this first picture, you can see the super dark pigmentation on the elbows and the overall skin bronzing. The bottom picture, you can see that the mucous membranes have even been affected by the melanocyte stimulating factor. The surfaces of the palms also have darkened areas from the melanocyte releasing factor as well. And then this bottom picture, you see areas of bronzing, and you also see areas where the pigmentation is not there. So that is another way that this disorder can present, vitiligo. So lab tests that you'll be doing, you're going to be expecting your potassium to be high. You're expecting your calcium to be high. Your sodium is going to be decreased. Your patients are craving salt. Whenever you crave something, there's usually a reason for it. Increased white blood cells. The increased white blood cells are also contributing to the problems with the immune system. Your BUN and your creatinine are increased. Your kidney function is getting worse. Your blood glucose is going to be normal to decreased because within Addison's, it blocks gluconeogenesis. So you're going to have a lower blood sugar. And then the amount of cortisol in your blood or in your saliva will be decreased. So we talked about adrenocorticotropic hormone. If we are doing a provocation test, we're trying to get something to happen. So when ACTH is infused, And then you're measuring the cortisol levels over different periods of time after the injection of additional ACTH. You're trying to provoke the body to make cortisol. With primary adrenal insufficiency, the cortisol levels do not rise. Should be rise, not rise. With secondary adrenal insufficiency, the plasma cortisol levels increase. So if the patient is in active crisis, this test cannot be performed. Also need to be looking at the heart to see if there's any electrolyte abnormalities that are affecting the heart and if there's any dysrhythmias. The x-rays of the body, CT scans, MRIs, to be able to find if there is a tumor or if the adrenal gland is actually atrophying. Big thing is we want to treat our patients individually, and our primary goal is prevent circulatory shock. Circulatory shock is when multiple systems of the body don't get enough oxygen. When they're not getting enough oxygen, then what happens? What happens is that cells will start to die and our patient really starts to tank. So our assessment is cardiac. Well, the big reason why is because of the high potassium levels. High potassium levels are associated with an increase in dysrhythmias. We need to administer saline infusions to help correct the dehydration and to restore the fluid volume that you should have. Make sure that the patient doesn't go hypoglycemic and make sure they're in a safe environment, that they're unlikely to injure themselves. So sodium polystyrene, this is a way that we can treat for hyperkalemia. Also remember that with hyperkalemia, the T waves are peaked. And so pull that up on Google. You'll be able to see very quickly on an EKG if a patient has significant hyperkalemia. So you want to frequently assess vital signs and monitor for dysrhythmias as well. Medications, you may need glucocorticoids, different steroids like prednisone, mineral corticoids. This is the aldosterone. So we may need to have that on board as well. Vasopressors, these are used for patients with severe persistent hypotension. And antibiotics will be used for patients with infections as well. And so we've talked about the glucocorticoids. We've talked about the mineral corticoids as well. And so when we are replacing with mineral corticoids, remember this is like aldosterone. So it's going to affect the salt. When salt is being retained, then fluid is retained. So you need to monitor, do daily weights on your patient, do frequent blood pressure checks, and examine their electrolytes. So there's several complications that can happen. You can have an acute adrenal insufficiency. So that is an Addisonian crisis. That's when it happens quickly. Hypoglycemia, you have too little sugar within the blood. And so what happens is when you don't have enough steroids like cortisol, then your insulin that you do make, your body becomes more sensitive to it. So it pulls the sugar out of the blood and it puts it in the cells. So you have too little sugar within the blood. Hyperkalemia we talked about. Remember, sodium always does the opposite of potassium. So hyponatremia. And when you lay down and change positions, your blood pressure may significantly drop. Okay, that's it for this lecture. Thank you guys, and there will be more very soon. See you next time. Bye.